Okay, welcome everybody to the reboot of our ACSM Biomechanics Interest Group webinar series here. I'm Ross Miller. I'll be the head co-chair of the BIG for this upcoming year. We also have as hosts our newest co-chair, Srikant Vallabh Josula. I'm still learning the last name. I think I've got it pretty close. And then also Rumit Singh, one of our more established co-chairs, also here as well. So thanks guys for helping me host today. Our speaker today is Dr. Brian Pietrosimone, and this is a special presentation because it's not just any presentation. It's a presentation in honor of our 2022 BIG Mid-Career Award. The Career Award winner always gives a presentation at the ACSM annual meeting for us, and we don't really have time for a great deal more than that in terms of presentations, but we thought this is a pretty major award, and it's one that would be nice for the BIG community to hear from the Mid-Career Award winner. So that was the motivation behind having a webinar for this one. The Mid-Career Award is chosen for an individual on the basis of the impact of their biomechanics research and their engagement with ACSM. It's selected by from all the applicants for the award in a given year by the co-chairs and by a panel of previous career award winners. If you were to look at Brian's CV, you might think that this is not a mid-career award, that this is a career award. He has a truly impressive record of scholarly output for any career stage, not just for a mid-career stage. He's going to speak today on understanding the biomechanical and biological consequences of ACL injury, a step towards osteoarthritis prevention.
Well, thanks, Ross. I really appreciate it. That was nice of you to say. I'll give you that $20 next time I see you. Thanks for setting this up and for ACSM BIG for the award. It was really humbling. But what I'd like to talk a bit about today is just some of the work that we've done recently trying to link biomechanics and biology after ACL injury, and talk about how maybe we can actually make the jump from some of the lab-based work into the clinic. And I thought one of the other things that I would do maybe throughout this is just share a few times, there's a lot of times, but a few times where different presentations, I think early in my career, where we've gotten questioned and we've gotten I guess critiqued, I think led to some really kind of new cool research, when you listen to the critiques of some of your fellow researchers. So I've added a few of those points throughout. Those are my funding disclosures and kind of a brief outline for today. I want to just set the stage for post-traumatic osteoarthritis and some of these long-term consequences after ACL reconstruction. And I want to kind of describe the biomechanical changes after ACL and then link those biomechanics to kind of the harmful biological joint changes, all right, that we see, so that we can eventually, talk about some of these intervention strategies and targets where we can use biomechanics to target the biology. All right, so what is osteoarthritis? If you kind of read the definition, it's fairly long and convoluted. So I put it into pictures because that's easier for me to understand. So osteoarthritis really kind of affects movable joints, all right? And what happens is, there's some sort of cell stress or trauma, which is caused either by, idiopathic causes over time, or potentially it could be a large scale trauma, like, a joint injury, right? An acute incident. We'll have some sort of maladaptive response, all right, within the tissue, which causes, abnormal changes to the composition of and biology of the tissue, which eventually cause structural changes, all right, which oftentimes is where we, diagnose OA or osteoarthritis, on an X-ray, all right, which then leads to the illness, all right, or the symptoms that people feel. Now, what's interesting, what we've realized over like the last decade is that, most of us think about osteoarthritis as changes in the cartilage or bone, but what we realize is that there are multiple different tissues involved, all right? So this is really, truly a change to the entire, joint organ system, all right? I'll talk a lot about the cartilage and the bone because it's what we tend to look at early on. Right, but there's a lot of changes that are happening to many different tissues throughout the joint. And what this means is that bone on bone change that we see kind of an end stage OA, right? There are probably a lot of different unique pathways to that onset, which makes it really hard to treat, right? Because, different people will have different phenotypes and a different pathway to that end stage bone on bone. So if we look at just knee arthritis, which I'm interested in, I want to talk about today by the numbers, knee osteoarthritis, so just to the knee, right, is the 11th leading cause of disability worldwide. If you look at all osteoarthritis, all joints, it's, top 5, but just the knee, it's 11th leading cause of disability worldwide. Now, most people will develop osteoarthritis or be diagnosed at the age of 55, right? Which, means that there's going to be a lot of time, all right, that people are, have disability related to this, condition. When we look at all the other, I think, joints that osteoarthritis affects, we see that this knee joint, right, is really kind of the driver of disability. When we look at all of these different joints that are affected. Now, we used to talk about knee osteoarthritis as being something that stops you from moving, but is not necessarily a deadly disease. Well, this is kind of been challenged. This idea has been challenged recently. If we look at some data submitted by ORSI to the FDA over the past decade, what they've seen when grouping some of these large epidemiological population-based studies together, like Johnston County and most, right, is that if you take patients who have radiographic and symptomatic disease, and after adjusting for age and sex and race, and look at them compared to people with no OA, there is a 23% increased risk of premature death. Right, so we're seeing that osteoarthritis, really is a serious disease when we look at its, effect on mortality. Now, how you get to osteoarthritis, there's a variety of different factors. And I think that this figure is also oftentimes hits home for me, because you can think about the individual's susceptibility, right? And you have all these different risk factors like age, sex, obesity, race. And then you have a joint specific susceptibility to OA, all right? And that can be a variety of different things: strength, alignment. One of those factors that we see very predictive of, developing osteoarthritis, and particularly making a joint susceptible, is injury. And that's kind of what I want to focus on, today. We talk about injury after osteoarthritis oftentimes as post-traumatic osteoarthritis, all right? And we see depending on what study you look at, between 12 and 35% of all osteoarthritis cases, affecting the knee, occur following an injury. All right, so that's a significant subset there. What's interesting, right, is that because knee injuries are most common in people who are younger, right, and more active, this means that, potentially this post-traumatic osteoarthritis is going to develop earlier in life, all right, than people who develop idiopathic OA over time. And because people who develop PTOA are younger than those who develop idiopathic OA, right, it causes more disability, right, because those people want to be more active. So they inherently have more, disability associated with it. Now, one of the specific injuries that we've been interested in really kind of looking at osteoarthritis development in is ACL injury. We've all, probably have heard of this ACL being injured oftentimes in cutting, twisting, pivoting, jumping type sports. All right. This was an interesting population study out of Minnesota, where it showed like the annual incidence, right, around 70 people per 100,000 person years. All right. Males were actually had a higher incidence than females, and this is probably likely due to American football. If we look at like sports, females tend to have a higher incidence, right? But if you look at the incidence at the time of or I guess chronological age, we see that females tend to actually tear their ACL or injure their ACL earlier in life than males. And this isn't trivial when you think about the development of osteoarthritis that we're going to talk about here, happening potentially earlier, right, in females than males, because they're developing these or sustaining these injuries earlier in life. Now, the other thing to keep in mind is that in the US, most people will choose ACL reconstruction. So this study found about 75%. If we look under 18, right, at our younger individuals, it's essentially almost everybody, right? So 98% of people choose ACL reconstruction. And if we, depending on what study you look at, all right, it's, I think, between 3 and 17% of people will essentially, have a re-tear of that graft, and about 82% will return back to some level of physical activity. But what we see as I guess a bigger issue, right, is this persistent long-term consequences following the injury. So this is data from the MOON cohort, which is our largest prospective ACL cohort in the US, and they use the International Knee Documentation Committee Index. So 100% here is full function of your knee, and this is a subjective form. What we see is that people do improve, right, at 2, 6, and 10-year outcomes compared to right after injury, but you can see there's still a substantial deficit in their self-reported function. And their 2-year outcomes are the same as their 10-year outcomes. So we have a small window to likely make improvements, all right, where people kind of plateau and stay the same, for that decade. We did another study where we actually looked at the radiographic evidence of osteoarthritis in the first few decades after ACL reconstruction, or in people who remain deficient. What we found is within that first decade, and again, this is incidence on X-ray, so this is a radiographic change, that regardless of reconstruction status, about a third of people develop osteoarthritis in that first decade. And if you look at the second decade in ACL reconstructed people, it's essentially a coin flip. All right, about 50% will develop it. All right, so this is a large amount, of people, and what we're realizing, right, is that our best efforts, reconstruction and rehabilitation, don't necessarily decrease that risk of ACL or post-traumatic osteoarthritis development at this point. So why? Well, if we look at the standard of care, essentially we have our ACL injury. 10 years later, we get knee OA, right? We treat people between 2 and 6 months post ACL reconstruction with standard rehabilitation, and then we send them out between 9 months and 10 years, right, to have some sort of physical activity. And there's not much we do to actually decrease this risk of knee OA in this time. And oftentimes when I talk to clinicians, I say, why? Like, what stops us from really kind of addressing this major concern? And it always comes back to this idea of we really don't know what those modifiable risk factors are. What can we do, all right, that could essentially decrease that risk of PTOA? And this is where we've gotten interested in actually thinking about the mechanical changes, right, that could be targeted, right, to impact this disease development. So what we do know, right, is that there are biomechanical changes after joint injury, right? People start to walk differently or move differently. And then there are physiologic changes, right? There are biological changes to the tissue. And we also know, from several previous experiments, that there's an interaction, right, between biomechanics and biology, right? And if we could intervene, if we could understand this, cyclical association, right, and intervene appropriately, potentially we could prevent joint breakdown and prevent joint pain. And that's essentially, what we've been looking at over the last few years, and I'll try to summarize some of those findings to kind of try to help make, sense out of that question. So, what are the biomechanical changes that actually occur after ACL injury? There's a lot of, tasks that you could look at. We've been really focused on walking gait biomechanics. And you can ask why walking gaits? Well, one, they acutely are altered after ACL injury. So we know that they're one of the first things to change, right? We see that these alterations persist over multiple years. And we know just by the sheer volume of walking that a normal person does, throughout the day, right? A small change in our movement, our walking biomechanics could be magnified, right? That could snowball just by the number of steps that we take throughout the day. All right. And we also know from a variety of different studies that if we're able to locate or identify, I should say, the biomechanical changes that are most deleterious to the joint, we have the ability to modify them. So our first study here, where we kind of looked at some of these changes, it was a longitudinal cohort study, and essentially we looked at people who were ACL reconstructed at 6 and 12 months post ACL reconstruction, and we made a few different comparisons. We looked at between limb comparisons, and then we actually matched them to a uninjured control group that had no history of lower extremity injury, and we matched them on age, sex, and BMI. Here's just kind of a look at, you could read the paper. There's a several, I guess, different biomechanical changes. I want to hone in on a few of them that we'll kind of talk a bit about throughout the talk here today. So this is obviously vertical ground reaction force, time normalized across stance phase. So for those not used to seeing this, right, you have an increase in this vertical component of the ground reaction force initially when you heel strike, right? Then about mid stance, we usually see a decrease, and then a increase again prior to push off and removing the foot from the ground. Right. With our ACL reconstructed individuals, we saw that there is actually lower vertical ground reaction force in that initial impact. All right. And then we saw an increase, right, in force at mid stance, all right, and a slight decrease again, at that second hump of the vertical ground reaction force. And this was consistent compared to our uninjured control group at 6 and 12 months. Right, so they were underloading early. They had slightly higher loads at mid stance, and we've been thinking of this as they essentially have a less dynamic waveform here in their loading, a more sustained loading, throughout stance. So an underloading early, but a more sustained loading throughout stance phase. Whoops. When we looked at our knee flexion, another very common variable to evaluate, what we saw here was that knee flexion was decreased early in stance, and they also did not get into as much extension, right, through mid stance. Okay, so they had a stiffer knee where they had less flexion and less extension, all right, throughout that mid stance. At 12 months, all right, they were able to regain that extension, but they still had decreases in that initial flexion. Now, what was interesting is that when we looked at that between limb comparison, what we saw was that they were actually becoming symmetrical in many of these outcomes over time, right? So here's the look between 6 and 12 months, and you can see, right, that there were differences at 6 months, in the injured limb compared to the uninjured limb, where they were, underloading early on. That all went away at 12 months. And at first we were like, this is great. But then we realized, all right, they're increasing symmetry, but they are moving away from the uninjured control group. All right. So they're bilaterally underloading that first peak. All right. And changing the uninjured limb to match the injured limb rather than becoming, I guess we could say, more normal, or closer to those uninjured controls. So how the heck are they doing? First, we looked to see if, kinesiophobia, right? If there was a fear avoidance, right? And we saw that there were really no associations between Tampa scale kinesiophobia and any of our major biomechanical markers through gait. But what we did notice, right, was that they were actually slowing down their walking speed. All right, so they were essentially decreasing their habitual walking speed between 6 and 12 months. All right, it wasn't statistically different at the 6-month time point compared to our uninjured controls, but you can see at 12 months it was. And this decrease in walking speed, also predicted about a third of the variance in their change in that initial peak vertical ground reaction force. Not so much in the knee flexion angle and moment. All right, but a third of the variance, right, in the VGRF. So the walking speed, the decrease in walking speed is obviously a concern, right, that may be causing this, all right, but it also leaves 2/3, right, of the variance unexplained by just changing walking speed, right? There were some neuromuscular changes that they were making, all right, to adjust towards their injured limb rather than normalizing their gait. One of the other things that we've seen, right, over time is that people take lesser steps. So this was a study by one of our postdocs, Caroline Lisi, who looked at individuals who took high, moderate, and low steps per day and evaluated some of these different biomechanical outcomes. And what she found was that there might be this underloading phenotype. So individuals who took less steps per day after their ACL reconstruction, right, also tended to have this early underloading in their gait per step, and seem to have lesser, knee extension moments. All right, so suggesting that individuals who take less steps also potentially will have lesser peak loads. All right, with each step. Right, suggesting again that there might just be this underloading type of phenotype after ACL reconstruction. All right, so when we looked at these changes, the question was, okay, well, is this underloading a good thing or a bad thing, right? Is this lesser load that they're taking a positive, beneficial adaptation to maintain healthy joint tissue? Or is it potentially detrimental to the joint tissue? So what we sought to do is actually link some of these mechanics to some biological changes. So we looked at some different fluid biomarkers, as well as I'll show you some imaging markers, right, of tissue degeneration. Our first study, what we did was we looked at some of these gait biomechanical outcomes associated with, a blood marker of type 2 collagen turnover. So in this group, we had ACL reconstructed individuals that were about on average, about 3 years post ACL. And you could say there's a heterogeneous sample of some of these, different graft types. What we found, all right, was that individuals who had lesser vertical ground reaction force peak, all right, actually had higher C2C to CP2 ratio. So this is a type 2 collagen turnover marker. So higher ratios suggest more breakdown to synthesis of type 2 collagen, suggesting that our group, right, who was loading less, all right, actually had worse cartilage turnover. So at first we were like, this doesn't make sense. That's not what we expected to see. All right, we must have done something wrong. Let's redo that study. So we essentially got individuals who are a little closer to ACL, and we tightened up the group quite a bit. So we had people who were 6 months post reconstruction, and they all had the same, graft type. They were all, most of them were symptomatic, right? And we evaluated different markers. Since they were closer to injury and reconstruction, we looked at a pro-inflammatory cytokine, IL-6, and then also an enzyme, MMP3, that's linked with early cartilage matrix degeneration, right? And what we found was something fairly similar, even though we were evaluating a few other different markers. So we looked at vertical ground reaction force peak and loading rate, and found that people who had lesser loading rates had higher MMP3. We also evaluated knee adduction moment to look more at some of the medial compartment loading, and found something with lesser CAM, all right, had greater MMP3 and greater IL-6, so more inflammation, right? Suggesting that this lesser loading was associated with some of these, deleterious changes in biology. We also said, well, let's see if people who actually walk, this was kind of a snapshot. What if we had people walk for, a 20-minute period, all right? Would they have greater or a lesser biologic effect based on their peak loads? So we had individuals essentially walk for 20 minutes, and we took measurements, serum measurements of cartilage oligomeric matrix protein, which is a marker of cartilage breakdown, and it's fairly mechanosensitive, so you can see a change in it acutely following 20 minutes, 30 minutes of walking. And what we saw was that individuals who actually had lesser peak vertical ground reaction force and lesser loading rates, all right, after 20 minutes of walking, had greater change in comp, higher comp scores, all right? Again, suggesting, all right, that lesser loading was associated with some of these worse biological changes. Additionally, we looked at self-reported function. We saw that people who had lesser peaks at 6 months in their vertical ground reaction force actually had worse self-reported function, more symptoms at 12 months. So at this point, we were getting confident that actually this lesser loading may be a biomechanical marker of these biological changes. But what we were getting as critiques is, well, you're looking at very systemic changes, right? You're looking at these serum-based biomarkers or plasma-based biomarkers and patient-reported outcomes. We need to understand really what's happening at the tissue level. So what we sought to do is actually use a novel MRI technique that essentially looks at the compositional change of the cartilage. So we're all used to maybe looking at structural changes, right, of the cartilage. And what this technique does is use multiple different spin lock times, all right, that we can actually superimpose on each other. And we can look at how long it takes, right, for protons to move from the magnetic axis, right, to the anatomical axis when you stop the magnet at specific spin locks. And then what we can do is essentially map in a voxel by voxel manner those relaxation times, all right, of those protons, right? And larger, or I should say longer relaxation times are associated with worse proteoglycan content within the cartilage. And a proteoglycan, right, is a macromolecule within the cartilage that really stops, or I should say resists compressive forces to the tissue. All right, so if we see a decrease in proteoglycan content within the tissue, all right, this could suggest that we have early arthritis that is occurring. All right, so if you look at, this is just one of our soccer players, 12 months post ACL. This is the same segment, right, of their ACL reconstructed limb and their contralateral limb. You can see two things. One, there's increased T1 row relaxation time. So you can already see some of these changes in proteoglycan content within the cartilage. The other thing that you'll notice is that there's a swelling of the cartilage. So if you were to just look at this in 3 dimensions and look at the morphological change, you might say, wow, they're actually doing pretty good. It's nice thick cartilage. But what we see here is actually there's a change in the tissue quality. So what we sought to do is actually compare some of the biomechanical changes to some of that tissue quality change early on, right at the joint level. And what we saw was very similar, I guess, storyline to that other data that I was showing, right? That individuals who had lower peak vertical ground reaction forces, right, lower loading rates and lower CAM, actually also had these higher T1 row relaxation times or worse cartilage composition, lesser proteoglycan. So, so at this point, what we're hypothesizing, right, is that these lesser peak loads are associated with some of these, deleterious changes in the cartilage. What was interesting is that at the same time, there were some other groups across the continent in California that were showing some different data. they were actually looking longitudinally at changes in T1 row and T2 mapping, similar MRI outcomes as we were. And what they were showing is that individuals who were actually increasing in CAM between preoperative and 6-month time points, right, were actually having worse T1 row, which is the exact opposite of what we were seeing. So we recently have been asking, like, why? Why is that? Is it just a difference in people from North Carolina versus California? All right, or is it maybe a difference in the perspective, right, that we're essentially looking at this group from? So what we did was we took individuals, basically their CAM values at 6 and 12 months post ACL reconstruction. We did a cluster analysis to cluster individuals using their MRI or T1 row values, all right, into people who had high T1 row, which is bad, and people have low T1 row, which is good, right, at 12 months. And what we saw is this group that had the high T1 row actually started out really low compared to a uninjured control group, CAM, all right? And at 12 months, they did increase, but they didn't start excessively loading, right, their joint. Okay, they actually just kind of moved closer to what the uninjured controls were doing. Okay, so the reason that some of these other, we concluded that we're all saying probably the same thing. The reason some of these other groups were saying that the worst, people who are having the worst T1 row were actually increasing was because they were probably starting so low, right? In some of these loading metrics. All right, so this was kind of I guess a education for me, right? That these control groups are really important, right? To be able to kind of have a lens to really evaluate your biomechanical data, even if you're looking at longitudinal data, to have some control, all right, is really important. The other question that we had, right, was that we were seeing changes at different points in the stance phase. All right, we see changes early on, which is really what we were kind of focusing on. But we were seeing changes also in mid stance, and our question was: are these early changes really what is affecting the tissue, or are there other parts of this loading profile that actually may be more impactful, or I should say important or significant in really changing these tissue characteristics? One of our doctoral students, Elizabeth Bjornson, actually just published a study where she evaluated this. She essentially ran correlations between the T1 row and the vertical ground reaction force, throughout stance. And what she found was it was really the greatest associations, the highest associations. So this is just a look at the Pearson R, right, throughout stance, right? We're at mid stance, the area where our ACL individuals were not necessarily offloading that limb, all right, similarly to that control group, all right? So, this is kind of also made us think about evaluating or thinking about this entire profile, right? Instead of really just looking at some of these discrete points, right? Really, if we're going to adjust or make changes in this profile, we have to think of, affecting the whole stance phase. The other thing that we've been looking at is other, measurements, in addition to just, some of our magnitudes of our biomechanics. And one of the things that has been fairly predictive is walking speed. So I mentioned it before, as our group was slowing down, what we've seen is if we take out all the other mechanics that we're looking at, walking speed also seems to be predictive of people who have changes in this biology. So in a study where we looked at differences between walking speed, there we go. At 6 months, we saw people who walked slower at 6 months had worse T1 row at 12 months. If we looked at a group who was about 4 years post ACL reconstruction, we saw that group actually had who walked slower had worse type 2 collagen breakdown, right? And then when we used a ultrasound method to evaluate the deformation in the cartilage over a 30-minute walk. Individuals who walk slower over that 30 minutes actually showed more compression, right, or deformation of their cartilage over that period of time, suggesting that potentially, right, this change in our mechanics and walking slower can actually cause more sustained loading to that joint and potentially more strain to that tissue. The other thing that we've seen is that lesser daily steps, all right, actually is associated with changes in potentially cartilage resiliency. We had individuals wear an accelerometer over the course of 10 days, and we tracked their daily steps during that time. And then we also had them come in and walk for 20 minutes on the treadmill, and we took measurements of their comp pre and post. And what we saw is that individuals who tended to take less steps per day also, had higher cartilage breakdown, all right, during that standardized walking protocol. So one of the other, major, I think, issues that people brought up, all right, and oftentimes when you talk to people who are not biomechanists, they always say, is it the biomechanics that's changing the biology, or is it the biology that's changing the biomechanics? And we're biomechanists. We're always like, oh, it's the biomechanics, obviously, that's changing the biology. But we sought also to answer this question, and I think it's kind of led to some different ways to look at things. We had some of this data lying around, so we sought to kind of look at something to try to answer this. We had individuals right after injury, so within 6 days post ACL injury, when they came into the orthopedic clinic, we took synovial fluid draws from their knee. So we actually got synovial fluid here rather than serum or plasma. And then we looked at their biomechanics at 6 months following their ACL reconstruction. We specifically looked at one of those enzymes that I've talked about previously as related to cartilage matrix degradation, so MMP3. And what we found was that this group who had the highest MMP3, 6 days after injury, also seemed to have, right, that lesser loading early on and higher loading at mid stance, all right, at 6 months. And again, probably that stiffened knee that we've talked about at 6 months. So this suggests that potentially, right, there is this cyclical relationship. And what we needed at this point was really to, develop a model where we could look at the mechanism. Because right now, all we really had was observational data, all right, being able to show associations and really no mechanistic link between changing biomechanics, right, and changing biology. The other question we got was, is it always underloading or could it be overloading? Well, yes, it's probably, both. Depending on the movement that you look at, underloading may not always be the issue that's affecting some of the tissues. So, we looked at jump landing and some of these T1 row relaxation times, and what we found was the opposite here, right? People who had higher vertical ground reaction forces and knee extension and lesser knee extension moments, all right, during landing actually had worse T1 row. So depending on the task you're looking at, right, like, this could affect the tissue somewhat differently. The other thing is when we looked at time post-injury, even in the task of walking, what we saw, right, was that early on, if we separated the groups into people who were asymptomatic after ACL versus those who were symptomatic, our symptomatic ACL individuals in the first 12 months tended to underload, right, compared to our asymptomatic. But over 24 months, all right, they actually took on this excessive loading pattern compared to our asymptomatic individuals, all right, suggesting that there could be an interaction over time where unloaded tissue actually becomes overloaded, all right, as we move farther from injury. Now, what was interesting, when we get back to this idea of being able to look at mechanism and trying to find a template, right, for good gait, all right, or normal gait, all right, what we saw is that in our symptomatic people at different time points post-injury, right, they were all over the place. Sometimes they were underloading, right? They had this less dynamic. Sometimes they had this very dynamic waveform, right? But when we looked at our asymptomatic individuals at all these different time points, what was really interesting is their profiles were almost identical, like right on top of each other for that vertical ground reaction force at least. So we thought of this, and we've been thinking this as potentially a template, right? For actually moving our individuals to something, all right, that could be, more normal to evaluate, right, this mechanistic link. So how have we done that? What might be some interventions for targeting joint biology? We've been working with a close collaborator here at UNC, Jason Franz's group, for a while now, utilizing this idea of real-time biofeedback, right? That can essentially, measure that first peak of that vertical ground reaction force in real time, output that to a screen in front of the individual. Then we can adjust the target as we desire to essentially try to change that waveform in real time. We just finished up a project where we essentially did this, all right, and we used a variety of different types of loading conditions. With this instrumented treadmill. So we had people come in and do their usual walking, symmetric loading, where we tried to make them equal. Then we increase their loading by 5 body weights or decrease their loading by 5 body weights. What was really interesting is we take people who are ACL reconstructed or 6 to 12 months post-reconstruction who are typically underloading, and we applied this feedback that increased that initial peak by sought to increase it by 5 body weights. All right, and what you'll see right there, 5% body weight. So what you'll see right there, all right, is that this is a small change in that peak, all right, and it reestablishes that dynamic waveform right throughout stance. We also see that by teaching them to increase, all right, that initial peak, that they actually increased knee flexion as well. So it had almost this generalized, I guess, normalizing effect. When we asked them to decrease their loading, all right, because one, it was hard for them because they were already had such a low initial peak, but you could see that it resulted in this more sustained loading throughout stance here. And they had more knee flexion, but they had more knee flexion throughout all of stance. They weren't going back into extension, so they were almost walking on eggshells, as you can see there, which is not what we want, right? It actually is probably stiffer when you think about the excursion. What was also really interesting is that increased loading condition. When we looked at serum comp pre and post in a group of people that typically showed greater comp during their control walking, we actually saw that increasing that dynamic nature of that waveform and increasing that knee flexion resulted in less comp during that overloading condition, right? Suggesting that there is a mechanistic effect between changing the biomechanics and seeing a change in that biology. So currently right now we're taking this step forward, right, of actually doing a longer trial, right? We're bringing people in, we're randomizing them to real-time gait biofeedback or a sham. And the lab is right next to me, so I don't want to yell because if someone's in there doing the sham, I don't want them to know. But essentially it will measure during just their normal walking, their step length, right? And essentially we put their step length as their target and we zoom in really close and they're trying to just keep their step length normal, all right, throughout time. And what we found is that doesn't change any of their biomechanics, right? But they're really trying to just be normal, during that time. So we're using a sham controlled trial. We're evaluating the retention and transfer, their changes in their tissue composition and biology. What we've sought to use as a target here is 1.12 body weights. So instead of just increasing them by 5% everybody, we're actually trying to bring them all to the same target. And the reason we've chose this target is one, 1.21 body weights was what our uninjured controls are at for that peak. And which is like fascinating to me, it's what all of our asymptomatic ACL were at. Like it's the same, it was the same, value. So we've used that now as kind of our target for, normalizing gait. So this is a case study that we use to kind of, prepare for this study. But you could see here that we've used motor control principles across 18 sessions to do this biofeedback, and we kind of ramp up the feedback and then ramp it down over 18 sessions. And you can see that in retention trials that we perform prior to each session, that the group by about 15, 16 sessions seems to be able to hit that 1.12 target without any feedback, all right, prior to their actual training session. And then in this one case study, what we actually saw is that between the baseline and 6-week post-test, that we were able to actually decrease T1 row, that measure of proteoglycan density, all right? We were basically able to improve proteoglycan density in the medial femur, all right, by about 7%. And that is equivalent to the difference between the injured and uninjured control. So essentially, we're making those injured limb look like a control limb. Again, that's a one-person case study. Hopefully in about a year, we'll have some better data, but it's promising. There's other interventions that we, I'll end it just briefly here saying that we've tried some other things to do something similar. We used a rebound OSER brace, all right? And that did result in some increases in peak knee flexion. And when we looked at comp, we actually saw that there was a subset of individuals who typically have higher comp that decreased with that brace. So it showed something similar. It just wasn't as robust of an effect as our real-time gait biofeedback, right? And then we're also looking at, the effect of changing walking frequency. And Caroline, Dr. Lise is actually leading that study right now. So that's all I got for today, and happy to take any questions. And I know this is going to be online, so if you end up watching this on Ross's YouTube channel, just feel free to email me, and I'd be happy to chat about this again. Like I was trying to say, a lot of the stuff that I've always found interesting that we've found, a lot of it comes from discussion and critique after some of these presentations. Thanks again.
That was fantastic. Thank you, Brian. I will open it up to the audience here for any questions.
I can open it up. Thanks, Brian, for the excellent talk. I really enjoyed it. I'm a little biased with the spine and head and trunk perspective always when it comes to ACL injury. So, and from my biased opinion, there's a huge weight that's above the pelvis. So, have you thought about from a motor control perspective, from an injury causation perspective, like what is the role of trunk and head control with injury, and how does that play a part in rehab perspective? So yeah, I'll leave it open-ended.
Yeah, actually, I'm not aware of anything above the hip, but no.
It does not exist, right?
Yeah, do that to people smarter people like you. No, I think it's an interesting thing, and I don't want to, I obviously know that there's some different work out there, right? That is really looking at some of the motor control, changes that are associated with the primary injury. And, I think there's a lot of interesting stuff talking about, or coming out even new about, the trunk and, how that's positioned in some of our dynamic movements. So I can't really speak to too much of that, just not where a lot of our work has come in. But, as far as, thinking about it in rehab afterwards, and specifically even in gait, a lot of where I've thought about it has kind of come down to how people are changing their walking. And, when we are teaching them to change their forces, how people go about it differently. And I would actually, eventually like to throw this back at you and see if you're interested eventually in talking about it a little more. But, people, will adjust their vertical ground reaction force or come up with ways to do it very differently. Some people, you can see them pushing down into the ground and, essentially going through more knee flexion and whatnot. And then some people get this bouncing type of movement as well, where there is a lot more, trunk, upper body, changes in their motor control strategies. When you ask them to decrease, you oftentimes will see a lean in their, in their trunk. So again, it's not something that I've really paid too much attention to right now. Not because I don't think it's important, just because we've been focused on, some other stuff, but I see it as something that would be really important in understanding how people, at least from our perspective, how people are making these changes to this one variable, and potentially who might have the better capacity to make these changes based on their ability to have, to be more variable throughout the system. One of the postdocs that I'm working with here, Courtney Armitano Lago, she's really interested in this idea of variability and, throughout the system. And what we've actually seen, and I'm sorry, this is going probably way in a different direction of your question, because I can't answer your question really. But she's actually looking at a lot of the variability measurements, around a variety of the different joints, and finding that people who are less variable actually seem to have a lot of these joint related changes at the knee joint. So these this idea of lesser variability potentially causing a more constrained or rigid system, right? And having less of effect is really interesting. I'll end this by saying, one of the difficult things is when you apply a real-time biofeedback, at least acutely, you make people more rigid, because they're trying to all hit that target, so they become more rigid or less variable, at least in those first few intervention sessions. So I don't know what happens over time, and I don't know what happens to the rest of the system in the trunk. But,
yeah, no, thank you. That sort of touched on what I was going to ask as a follow-up question, like as in terms of rigidity based on biofeedback, but I'll definitely pick your brain on it offline, and I would love to chat more.
Yeah, I would love to get you kind of involved, because we have a lot of the data. So if you ever want to pick through it and figure out a way that we could ask a better question, I would love it.
Yeah, absolutely.
Great talk, Brian.
Thanks, Dan.
I was just I'd say to, with what Rumit said, a lot of the gait biofeedback or the gait retraining methods with the trunk, lateral lean is certainly a method that folks use to manipulate the adduction moment in osteoarthritis patients, and forward trunk lean is another one in running groups to manipulate the flexion moment. That is common. My question, Brian, is so some of the discrepancies with the other groups, and you mentioned this with the group at UCSF and with the differences. And one of the things I always notice when I interpret these is the subtle differences in the outcome measures. We say they're the same, but you look at LSIs a lot. Limb symmetry indices with knee adduction moment and knee adduction moment versus knee adduction impulse. And when they're normalized to body weight or body weight times height. And T1 row is a ratio versus the absolute metric. And I'm wondering how you find that influences your interpretation, how comparable our data are.
Yeah, I mean, I think, I think that's a really good point. And I personally, I think the biggest issue is maybe not necessarily always, how we're normalizing, or if we're essentially, looking at it as how different is it from limb, the limb versus just the absolute value, which I should say it is an issue, but I think one of the other the major issues is that reference to a control, because I feel like when we're looking at the LSI, and I'm guilty of it too, as you pointed out, like when we're looking at the LSI, we really don't know how different both of those limbs are to, what non-injured people who, are similarly matched, right? How they're moving. And, I think that was the biggest I think the variable, I think that explained the difference and what we were kind of interpreting versus what other groups were interpreting, where they were saying it was this increase in loading over time that was associated. And right, that is not necessarily wrong, but I think if we interpret that from the idea of how we're going to intervene, and we say, oh, if increasing is bad, then we need to decrease some of those loads, and that could be actually detrimental, right? If you're not realizing that the increase is because they're trying to get back to normal from a really, really low value. And I think, for me, we've used interlimb differences because sometimes it's just the best you can do with the data that you have and the funding that you have to collect the information. But I think, really moving forward, we really need to think about having control groups, because people are changing bilaterally to a unilateral, and they're becoming symmetrical, but it's not necessarily, Terry Grindstaff always has like one of the best, visualizations for me, where he says, like, you could have symmetrically flat tires on your bike. It doesn't necessarily mean you're going to.
Yeah, absolutely. And then the second question that I had was about I guess, just in unpacking this idea of whether, more loading or less loading is good or bad, and whether we think that association is linear. You use some categorizations of low, medium, high physical activity or step counts, I think. And when we look at some of the biomechanical variables and grouping them as high, low, or thinking of them as continuous, do we see cut points? Is the association linear? Like, is there a threshold by which too much is not good anymore? What do you think?
I know. I want to ask you the same question, but
I know. I know. I want to ask Ross the same question too, from the simulation studies.
I don't know. I mean, I think what we're trying to do is basically we try to figure out a cut point for our, rehabilitation of 1.12, right, as something that not necessarily like a cut point where we just wanted people to move up, right? Well, we wanted people to try to get to a target rather than just pushing them in one direction. It's kind of along the lines of what you're kind of describing, that there's probably like a Goldilocks zone, right? Too much is bad, not enough is bad, but there's a zone that is good. And if we just push people in one direction, it's probably not the best way to do it, right? We need some sort of target, which is why we chose that 1.12 for the reasons that I explained before, was that it seemed to be what our controls and our asymptomatic people were at. But as far as like, really thinking through, is less loading causing the problem? I've been trying to figure out how the heck less loading causes the problem. And, I think the way that we've been thinking about it, I guess more recently, if I can go back to, maybe I can't. If I can just go back to like one figure here, right, is that, or easier said than done, right? Is that, potentially it's not the lesser loading here. It's just this sustained loading. Like, we have to think about it as like, stop looking at that discrete variable, but like how they're actually loading, right? And if they're sustaining this low load, right, on viscoelastic tissue that compresses in a time-dependent manner, right, like cartilage, okay, maybe what's happening is, or what I think is happening is it's causing more strain. right? It's causing more strain to the tissue because you're sustaining that low load versus you have this dynamic, higher peak load, but it's more dynamic and less sustained. And if you have a more sustained load and over a localized portion of the tissue because you're going through less range of motion, then maybe it's really the sustained localized load. And that's how we have to think about it rather than just, underloading. That's kind of more of just a working hypothesis right now. I haven't really, put it into the presentation yet, Tarek, but I don't know what you think.
I think that makes a lot of sense.
More data are needed.
Go ahead,
More
Derek.
data are needed.
Sorry, Derek, I didn't mean to interrupt you. I think that makes a lot of sense, that lack of underloading, I guess, if that's indeed what that is indicating. It's like if you look at most studies on, what type of loads is cartilage good at sustaining, what is it not good at sustaining, it's real good at this, but when you do this, that's what it doesn't like. When you just bouncing on it, it's okay, but or to some extent. But if you squeeze it and never let it up and grind it and twist it, it doesn't really respond too well to that. So if that's indeed what this ground reaction force is indicating is happening to a greater extent, I think that's a strong hypothesis.
Yeah.
I think the other thing is, like, with the sustained loading, when here technically we are only talking about a vertical force, but with the sustained loading in that during that phase is the shear motion that's actually potential, that from my understanding is worse for a cartilage, and that's what's happening during that sustained period of the long continuous load, like you said, like hold it down, and then you're trying to pair it up with the joint kinematics and see, is that just vertical load that you care about at this point?
Yeah, that's a really good point, Roman. I think that's probably like at least 3 more studies right there. Sorry. That's a really good point. Especially looking at what's happening to that force right in this part of stance would be really interesting.
Mm-hmm. So if we ignore the lack of unloading possibility for a moment, let's just focus on this first peak here, which looks like it's low in the ACL reconstructed limb. So if I just focus on that, and then I add in the data that you showed later that I think was on the jump landing, then it looks, and this kind of goes back to Derek's question, it's like, is it underloading, is it overloading? It looks like it's a little bit of both. Like they're underloading it when they walk, but they're overloading it when they jump. Is that accurate?
Yeah. Well, I should say the underloading during walking seems to associate with worse changes, and the overloading during jumping seems to associate with worse changes in the cartilage. But we did do another paper where we actually looked at that walking and jumping in the same people. And what we saw is that people who may walk with this underloading waveform don't necessarily jump with higher forces or land with higher forces or land with lower forces. So yes to your point of if we're just talking about the loading characteristic, but I don't know if it matches up with you're talking about the person.
Yeah. Okay.
That makes sense.
Sure. So I was thinking, like, especially if in an ACL reconstructed limb, like, you tear it, you have this single traumatic bout of massive loading, and that probably compromises things mechanically to some extent. And then when I'm walking on that knee, then I'm underloading it, and that's kind of my main common mode of loading, that maybe that's influencing the biology the most. So then maybe that compromises things. And then I go to jump and land, and I'm placing these large forces on it, and it's compromised in terms of its tissue properties. Then that all kind of makes sense to me. But if they're not actually necessarily loading it higher when they jump, then my idea breaks down a little bit.
Yeah, well, it just may not be in the same people, but I like your hypothesis that maybe potentially there's some greater neuromuscular change right in this person who ends up taking the slower walking speed, lesser load, sustained load, and then they can't necessarily attenuate forces when it comes to like a high jump landing, right? And they have higher, loading at that point.
Yeah. To follow up on that, so is there a pattern of loading in the same individual for walking compared to jump landing that you have seen in the same individuals?
And again, this was just a paper that we did with peak discrete variables. So we haven't looked at it, across like a pattern, which I think would be another way to do it and get out a little bit better. But in that discrete variable analysis, we saw that there was no association between higher loads during walking and loading during jump landing post ACL.
Yeah.
Meaning that people who were maybe our deleterious walkers weren't our deleterious jumpers. If that's a way to.
Yeah, no, that's super interesting. I'm just thinking out loud here. Like it would be interesting to look at the difference in their walking versus landing 6 months, 12 months, and 24 months, or something on those timelines to see maybe there was no association early on when neuromuscular adaptations have not kicked in, I guess, or like there has not been an established neuromuscular adaptation, but maybe that slowly brings them to do jumps one way and walk the other way down the road, like 2 years or so down the road. Maybe there's I'm just thinking out loud here.
I really like that idea.
Do you have any data on these folks running? Their loads and running look normal, abnormal, high, low?
Derek, what do you think?
I was gonna say maybe I should ask Derek this question.
I have a cohort of about 75 of them that we did walking, running, and landing on. And the associations between the limb symmetry indices, the magnitude of dysfunction or the magnitude of asymmetry across the tasks was weak to moderate. And it's interesting, and this isn't across time points like you mentioned, Rumit. I think Susan Sigward actually might have some good data and insight on that. I know she's quite into using running as a way to assess neuromuscular function. And I think there's such a difference in the way that we think about these tasks too. When we use a landing task, a lot of these athletes may not do sports with landings or land habitually, and it's not characterizing habitual movement patterns. But when we think of walking, we do think of, well, we measure walking to characterize a habitual movement pattern versus a test that's trying to characterize their function at a discrete time point. And so I think there's a difference in what the tests are useful for at different time points for sure. And certainly like there's benchmarks, running at 3 months and landings at 6 months and whatnot, and what they're useful for. But I think to expect symmetry in all tasks by assessing one of them is probably misguided. And it tells you why we really should assess multiple tasks when we're trying to think about, are these individuals symmetrical or not, or biomechanically sound or not.
Right. I agree with that, especially if like you can achieve, or some of these patients are achieving symmetry with gait in the wrong direction that we really want them to go, and doing it by like slowing down, right? And I don't know what that would look like if we looked at, how they would achieve symmetry in a jump landing, for instance, right? It'd be like totally different.
Yeah, absolutely. I think symmetry could be very misleading, and sort of my pet peeve with the return to sports testing is when clinicians look at clinicians like myself look at symmetry. So, and body's smart enough to figure out that if I land this far, and athletes are smart enough to figure out if I land this far, I can go back to play a lot faster. So symmetry is can be useful, but also can play against you.
Yeah, no, I agree with that. I mean, I don't think we want to achieve asymmetry, but I think achieving symmetry without achieving like the sufficiency of the movement, right? The magnitude is not, necessarily the whole picture.
Yeah. To Derek's point, I think that there is some value in looking at activities that the athlete might not be used to, because that gives us information on the variability aspect of it. Like, is there variability to adapt, especially if you're an athlete? And a lot of times ACL injuries might happen in unforeseen conditions or things that just were not habitual. Sometimes it can happen. So yeah.
Yeah, absolutely.
Okay, I think we're about out of time. Any other questions from the audience before we cut it off here? Okay, well, I'll thank Dr. Pietrosimone for sharing his very interesting research with us today. I'll thank our sponsors in the background here before we cut it off. Our gold sponsors is Delsys this year, silver sponsors AMTI Motion Analysis, OptiTrack and Vicon, and then our bronze sponsors Burtec and Novell and Qualisys. And we will get this one up on YouTube, and we will share that link for everybody to see. So thanks again, Brian, and thanks everybody, and we will see you next time.
Yeah, thanks
Bye.
again.
Take care.
Everybody.
Yeah.